assigned is persistent bacterial bronchitis. This can be a relatively new term because it came into existence only as early or as late as 1980 when the Australian team coined the term persistent bacterial bronchitis. But does that mean this term was not there before, or the disease was not there before? It is not like that. It's just that the scheme of things were being identified and given its due respect or terminology just for us to manage them effectively. So let us go through a scenario. Here is a 9-year-old girl. Am I audible? Here is a 9-year-old girl with 2 months of moist cough. Initial few days had URI symptoms like cold and fever, spit sputum at night, history of wheeze in the past, mild sleep disturbs the activity due to the cough, treated with nebulization and oral antibiotic for short bursts, clinically normal with the growth and development being normal, no loss of weight, there is no clubbing or cyanosis, chest is clear, sputum has been done, negative for AB, sputum cultures sterile so far, and the chest X-ray has been relatively normal. So this is a scenario which we also see in clinical practice, and most of the time it goes as asthma or bronchitis or sinus problem and stuff like that. But this actually is a disease entity called persistent bacterial bronchitis. And so what is persistent bacterial bronchitis? See, I am not able to see anything here. Audio visual, I am not able to see anything here. With regards to the definition, it is just that it's characterized by isolated chronic wet productive cough for more than 4 weeks without signs and symptoms of any other diseases, and usually they get resolved good with antibiotics for 2 weeks. So here the crux of the matter is it's a clinical entity. You need to have moist cough at least for 4 weeks, meaning there is no symptom-free interval in between. If you have frequent recurrent episodes, you cannot be clubbing them and calling them as protracted bacterial bronchitis. And there is no other signs and symptoms of any other known cause. And so naturally there is no other alternative diagnosis, and the cough resolves after 2 weeks of appropriate antibiotic. There are slight deviation to these definition. Around 40% of all children with PBB are bound to have recurrences. Audio visual, can you help me in this regard? I am not able to see anything here. So it has been called in various terminologies like persistent bacterial bronchitis, protracted bacterial bronchitis, and chronic suppurative lung disease. There are subtle differences between chronic suppurative lung disease and persistent bacterial bronchitis. The common organism here is H. influenza, Streptococcus pneumoniae, Myroxilla catarrhalis, and the viral thing has not been implicated so much, but studies show adenoviruses are there as an co-infection to the bacterial pathogen. And here you will be surprised, all these pathogens are the common cause of other respiratory illness, more so the upper respiratory problem like your sinus and also your otitis media. There is a terminology called extended PBB, meaning if the severe disease and cough resolves only after 4 weeks of antibiotics, it doesn't resolve in 2 weeks of antibiotics, it can take as long as 4 weeks of antibiotic. That is called extended PBB. And recurrent PBB, meaning more than 3 episodes in a year, is considered to be recurrent. Either in extended PBB or recurrent PBB, you need to investigate them further, like a CT chest. Why? Because you have to have an inclination towards chronic suppurative lung disease. Meaning in a CT, if there are changes in the bronchial wall, it is chronic suppurative lung disease. If there are no changes in the bronchial wall, it is chronic suppurative lung disease. If there are changes in the bronchial wall, it becomes bronchiectasis. So PBB is one end of the spectrum of a bronchiectasis spectrum, so that we have to have it in mind. So where is it? Okay, I'll manage. Leave it. So the pathogenesis is impaired mucociliary clearance, impaired immune function, and airway anomalies like your tracheomalacia, and bacterial biofilm. Yeah, that's okay. Bacterial biofilm formation. What happens is when there is a viral illness, it causes a airway injury, epithelial injury. So it opens a floodgate for a secondary bacterial infection. So that colonizes and stays for a long time. And these bacteria, sometimes they produce something called a biofilm, meaning they produce a matrix like around themselves. So they are safe and compact. It's like a bulletproof vest. So the antibiotics cannot penetrate. They do all nonsense as what they please, but they are not getting destroyed. So this goes on over a period of time. When that gets unaddressed, it goes on to a chronic suppurative lung disease and later bronchitis. And the risk group are daycare attendees and also people with tracheomalacia or airway malacia. And untreated, as I said earlier, it can extend up to bronchitis. That's the idea of treating persistent bacterial bronchitis. And this can happen at any age and more common in younger individuals. And usually it's only moist cough and nothing else. But there can be nighttime cough, shortness of breath during physical exercise. It can happen in a children who already has a wheeze, so naturally the wheeze also get exacerbated. And there can be rattling sounds because of the airway secretions in the larger airways. And systematic symptoms are usually absent, but tiredness can be there because of a disturbing cough at night, and they usually have a normal growth and development. And with regards to the clinical feature, there can be no signs at all, not even a tachypnea, clubbing or any findings on the chest, but occasionally there can be crackles and wheeze, and it can coexist with asthma, and chest x-ray can be normal, at times can have peribronchial changes, and often they are misdiagnosed as asthma. Here, then you might be wondering, any case can be persistent bacterial bronchitis. The crux of the matter is they should have persisting moist cough with no other alternative diagnosis possible at that particular point in time. So you have to have a high index of suspicion for you to make a diagnosis of asthma and for you to make a diagnosis of PBB, and it becomes weeks and months and years. So you have to be very clear by date and days. Is it for 4 weeks without a gap in between? Then you can with reasonable confidence call them as persistent bacterial bronchitis. Most common differential diagnosis in a scenario like this, more so in a younger individual, is foreign body congenital airway anomalies, because any airway malacia, they cause stagnation. Any stagnation leads on to coughing, right? And mucociliary dysfunction like your cystic fibrosis and PCDs, and of course your immunodeficiencies. And with regards to the difference between PBB and asthma, most of the time there can be always an overlap. PBB is a wet cough, whereas asthma is a dry cough. This cough, because of the secretion stagnation in the larger airways, with changing in posture, there can be increase in cough, whereas asthma is predominantly nocturnal cough, and rattles because of larger airway secretion, wheeze here, and here it improves with antibiotic, there it improves with corticosteroids. Here, if you are treating PBB with corticosteroids, it will not respond. Then you will call it as resistant or refractory asthma. Then it goes on, and it gets all sort of labels possible. So that you have to be very careful. So here again, the diagnosis is clinical, and investigation is for atypical, non-responders and recurrent. Atypical meaning anything other than moist cough. Though I said there can be crackles, there can be wheeze and all that stuff, but if those things are there, call them as atypical. Entertain a diagnosis of persistent bacterial bronchitis, call them as atypical. Also have an inching towards investigating them earlier. With regards to a typical form, if they are non-responder, not responding in 2 weeks, or if they are recurrent, coming at least 2 to 3 times in a year, then you have to evaluate. The evaluation, it has to be at least a chest x-ray. In older children, spirometry, usually it can be normal or can show obstructive evidence. Bronchoscopy, basically to rule out foreign body, and naturally there can be a lot of secretion, and ball can be sent for your culture sensitivity patterns. And HRCT, to see if there is a development of, it doesn't tell you it is persistent bacterial bronchitis, it can tell you if there is a development of bronchiectasis in these children. Of course, for completion to rule out cystic fibrosis and immunological deficiency, you can do a sweat test and immune evaluation in indicated patient. The treatment here is minimum 2 weeks course of amoxiclav. So amoxiclav, it has to be at a dose of 50 to 60 milligrams, and it is active against beta-lactamase producing strains of H. influenza and also Moraxella. The common strain implicated is H. influenza in PBB, and symptomatic cough after 2 weeks of antibiotic usually will respond to prolonged course of antibiotic, but you have to be clear that you are not dealing with anything else other than PBB, and other spectrum of drugs like your trimethoprim, sulfamethoxazole, other cephalosporins and macrolides, they all have not shown that much efficacy as compared to amoxiclav, because most of the studies are with amoxiclav. And weekly azithromycin, any chronic pulmonary disease, we have a tendency to put them on azithromycin, but that might not be that much helpful, and you have to be careful. The chance of resistance is also increasing. And the prolonged antibiotic, this is a double-edged sword. The rational being, the beneficial part being protecting your airway against the common respiratory pathogen, the bacterial pathogen, for an extended period of time. So whatever damage has been there, you give enough time for them to recuperate and recover. So that is the idea of it. On the flip side to it, the other end is prolonged antibiotic exposure disrupts the resident microbiota and contributes to pathoadaptation. What was a commensal becomes a pathogen. So that is also a possibility. So that you have to be careful. And prolonged antibiotic, unnecessarily you might be introducing antibiotic resistant strain into the community. So the duration of antibiotic. Now you might be wondering, what is the duration of antibiotic? As of now, any child who has been treated for a shorter period of time, less than 2 weeks, they quickly relapse. Now again, you know, even for sinusitis, the recommendation is 10 to 14 days, or at least 5 to 7 days after a symptom-free interval. So usually it becomes 2 weeks. So some are symptom-free after a few days, and they usually get better in 2 weeks. But whereas if they are not getting better, they are slowly getting better but not totally getting better, then here you can extend for 2 more weeks. Then there is no point in extending 2 weeks more and more in months and years. There you have to be careful. The BTS in British Thoracic Society in 2008, they gave a recommendation that all should be treated for 4 to 6 weeks of antibiotic. That was basically based on expert opinion at that particular point in time. And the latest American guidelines in 2016-17, they said minimum 2 weeks to minimize the side effect and antibiotic resistant is what is that is being recommended for now. If there is no improvement, as I said earlier, by 2 weeks you can extend for up to 4 weeks, that is 2 more weeks, and prolonged beyond 6 to 8 weeks or multiple course of antibiotic in rarest of rare situation might be required. Exception cannot always become a rule, you have to be very careful. British guidelines also recommends physiotherapy to mobilize secretion, but no studies are to prove the efficacy. But it is just common sense, because it is predominantly stagnation of your larger airway. Your chest physiotherapy, even if it is not going to do any good, it might not harm you. It's just a airway toileting and letting out your secretion. So any child with chronic wet cough without signs and symptoms of any other alternative diagnosis, you can entertain persistent bacterial bronchitis as one of the diagnosis or the first line diagnosis. Caution here is proposed criteria for PBB or non-specific and may lead to significant overdiagnosis and antibiotic overuse, inducing antibiotic resistance. Remember, PBB is characterized by prolonged duration of wet cough, and antibiotics should not be prescribed for all acute exacerbation of asthma. And thinking that if you leave it at 5 days, it can become 7, 10, 14 and 28 days, don't treat them early. You can wait reasonably for 4 weeks for you to qualify as PBB. So that should not be a problem. Here it is important to remember PBB is a forerunner for bronchiectasis. Thank you.